Next, we're gonna do distal hip traction. You're gonna take the patient's leg and you're gonna put it in 30 degrees of abduction, 30 degrees of flexion, and slight external rotation. So you're gonna grip around their distal tib fib. Try not to use your thumbs around it, don't bring them around. And you're gonna pull with your body weight. If the patient's hip is starting to move, you can bring in another subject. Have them stabilize at the ASIS. And you're gonna do the same traction. Ready? You'll get a firm end feel because of the capsule. Next, we're gonna do the posterior glide of the hip. You're gonna bring the patient's leg, bring the knee to flexion, hip to flexion, and you're gonna come across with your forearms and your hands. You're gonna grab at the lateral and medial condyles. Bring your hands across. When you pull down, use your body weight and try not to put pressure onto the patella. So you're gonna do a posterior glide. It's not much, but it's firm. Next, we're going to do an anterior glide of the hip. You're gonna put your patient in this beautiful position. One leg off the table, the other one, half his body laying on the table. You're gonna make sure his hips are level in neutral position. What you're gonna do is you're gonna bring the knee up and you're gonna bring your hand underneath the knee. You okay? Remember to breathe throughout this. You're going to bring your hand up towards the gluteal fold and you're going to do an anterior glide of pushing down. All right. Good job, sir. We're gonna start with arthrokinematics of the knee. We're gonna do knee traction first. What you're gonna do is you're gonna have the knee flex to about 25 degrees and you're gonna stabilize at the distal femur. You're gonna have a lumbrical grip at the distal tib fib joint. And so you're gonna stabilize and you're gonna pull in line with the tibia. So you're gonna pull away. Oh yeah?
I'm just trying to show.
You'll get a firm end feel from the capsule. A posterior glide of the knee. You're gonna bring the patient's knee up into 90 degrees of flexion. You're gonna stabilize at the distal femur at the condyles. What you're gonna do is you're gonna come in at an angle so it's perpendicular with the tibia and you're gonna push posteriorly. Anything? Yeah. Next we'll do the anterior glide. You're going to put a towel or a pillow underneath the ankle. You want to place the knee into 25 degrees of knee flexion. This one's not very good. You can also put a towel underneath the femur for the patella. But what you're going to do is you're going to hold at the distal tib fib and you're going to push at the proximal tib fib. So you're going to come at a perpendicular angle with the tibia and you're going to push anterior. Feel anything? Okay. We're going to do the standardized Ober test and the modified Ober test. You're going to have your patient side lying. Bring them closer to your edge of the table so that you can do this test. Make sure their thorax is in line with their hips, good proper position. You're gonna have a pillow in between you and your patient. What you're gonna do is bottom knee is going to be bent, top knee is gonna be at 90 degrees. You're gonna come around and stabilize under the thigh and lower leg. And you're gonna pull him into abduction and slight extension. Make sure they don't externally rotate at the hips. You're going to stabilize at the iliac crest and you're going to bring them down towards horizontal. And when you feel that iliac crest start to come up, that's the end of your test. So he stops about right here. So normal is horizontal. For the standard or the modified Ober, you're going to extend the leg. This is usually due to knee pathology if there's any problems there. So you're going to do the same thing. You're going to come across, support the leg and under the knee. You're going to bring them up to abduction and slight extension. Stabilize at the iliac crest. And you're going to bring him down by lowering your body. He stops just about right there. Normal is about 10 degrees below horizontal. Next, we're going to do a Thomas test. This is going to test the length and tightness of your 1 joint, 2 joint, hip flexors, knee extensors. So what you're going to do is you're going to bring the table up to the gluteal folds, and you're going to have the patient grab underneath their knee on their contralateral side. You're going to support behind the head and neck and behind the knees. So on 3, we're going to tilt back. Ready? Just lean back. 1, 2, 3. Beautiful, Jacob. Yeah. Okay, you're going to have your patient make sure their knee is at 90 degrees. Don't go beyond that. So you're going to stabilize at the ASIS, right there.
Moving.
And you're going to slowly drop the leg until you feel the ASIS come into your hand. So he stops about there. Normal would be his leg flushed with the table, which he's normal or slightly past it, and the knee would be at 80 degrees. So to test the 2 joint hip flexor, which is the rec fem, you're going to passively move the knee and see if his leg drops. I'm not sure if you dropped. To test the tightness of the TFL, you'll look for slight internal rotation of the foot. Right? And then for sartorius, you'll look for slight external rotation of the foot. Next, we're gonna muscle length test the hamstrings. You're gonna bring the leg up and you're gonna come under and stabilize the opposite leg. When you start to feel this come up, that's one of the ways to know that the test is over. Also, when you come into hip flexion, when the knee starts to break right about there, that's another indication that the test is over. So normal hamstring is usually 80 degrees. Next, we're gonna manual length test the plantar flexors of the ankle. You are gonna stabilize at the distal tib fib joint. You're gonna bring your hand underneath the ankle, and you're gonna use your forearm to bring them into dorsiflexion. So normal is about 10 degrees past neutral. Let's say he's about neutral.
I'm going to do the hamstrings as a group test. You're going to have your mobilizing hand at the distal tib fib. You're going to have your stabilization hand around the ischial tuberosity. So this is your motion. Go ahead and do that. Okay, thank you. And then hold, don't let me move you. Good. Now for medial hamstrings, I'm going to bring her out a little bit so the hip is medially rotated, and then until you rotate her foot. And same stabilization, same force arm. So hold, don't let me move you. Good. And then lateral hamstrings, you internally rotate.
Externally rotate the hip.
Externally rotate the hip, externally rotate the foot. Same stabilization. Okay, hold on a minute. Good.
Go.
I'm going to do the hip flexors as a group. Your patient's going to be sitting upright on the bed, sitting on edge, legs hung over the side. You're going to lift your leg up just a little bit. This is the movement. Okay. You're going to stabilize on the ipsilateral shoulder. Go ahead and hold that for me. Your force is going to be on the anterior thigh. So hold, don't let me move you. Good. And then now for iliopsoas, for only the iliopsoas, it's going to be the full end flexion of the hip. Same stabilization. Go ahead and do that movement. Thank you. Go ahead and hold that. And then you're going to stay, the force arm will be in the same position. So hold, don't let me move you. Good. Iliopsoas.
Go.
Okay. We're going to do sartorius next. You would put a pillow under the opposite knee. The sartorius flexes the knee, laterally abducts and laterally rotates the thigh. This is the motion. Go ahead and do that for me. Okay. So you're going to have force with both arms. You're going to press with on the anterior lower thigh, and you're going to pull the knee into extension. So hold on, let me move you. Good. Okay, next we're going to do the TFL. You would again have a pillow under the opposite knee. The TFL assists in flexion, abduction, and medially rotation. So go ahead and do that for me. Thank you. You can stabilize at the opposite hip if you need to, and then your force is going to be at the distal tib fib. So hold on, let me move you. Good. Okay, next we're going to do the medial and lateral rotators of the hip. You're going to have a towel stabilizing under the thigh onto the table. We're going to start with the medial rotators. If I was in the other room, I would obviously raise the bed, but I'm going to just crouch. Oh, I almost fell. So this is for medial rotation of the hip. You're going to stabilize in the way that you're pushing. You're going to push in the distal tib fib into medial rotation. Okay, so go ahead and do that. So hold on, let me move you.
Go.
We're going to do lateral rotators of the hip. So you're going to put the hip in that position. Thank you. You're going to stabilize on the side it's coming in, and then you're going to pull at the distal tib fib. So hold on, let me move you. Okay.
Go.
Okay, next we're going to do the glute minimus. Her leg underneath is going to be bent. The one on top is straight. This is the motion. Thank you. It abducts and internally rotates. My stabilization is going to be at the iliac crest. Force arm is at the distal tib fib. Hold on, let me move you. Good. Okay, next we're going to do the glute med. Her knee underneath is bent. Her top knee is going to be straight. The glute medius does abduction, internal rotation, and sled extension. Your stabilization is going to be at the iliac crest. Your force is going to be at the distal tib fib. Go ahead and do that motion for me. Alrighty. Thank you. Hold that. Go ahead and hold. Hold on, let me move you. Next, we're going to do the glute max. You're going to have the knee flexed to 90 degrees. You're going to have it lift up like that. Okay. And then you're going to stabilize at the superior aspect of the ilium. Your force arm is going to be at the lateral aspects of the hamstring, as close to the knee line as possible. So go ahead and do that motion again and then hold it for me. Okay. Hold on, let me move you. Good.
Go.
Okay, next we're going to do the adductors. You're going to support the top leg. This is so. This is the movement. Go ahead and do that. Okay, hold that. And then you're gonna push at the distal tib, distal thigh. Okay. Hold on, let me move you. Good. Strong.
Go.
Okay, next we're gonna do the quads. I'm gonna have a towel under her thigh to make it parallel with the table, but I'm also going to put my hand underneath there, just to make sure she doesn't come up off the table or push the knee into the table. Her knee is going to be fully extended. My force arm is going to be at the above the distal tib fib. So go ahead and do that motion for me. We're going to push into flexion. So hold, don't let me move you. Good.
Go.
Next, we're going to do the popliteus, which unlocks the knee after extension of gait into flexion. So what you want is the PT is going to bring the foot into external rotation of the tibia, and you're going to ask the patient to move it back towards the midline. If they can do that, then the popliteus is fine. Watch for compensations by bringing the leg medial.
Okay, next we're going to do the gastroc. We're going to have a towel under her distal tib fib. We're going to stabilize at the proximal
Ankle.
proximal to the ankle.
Yeah, just say proximal ankle.
Okay. So the action is plantar flexion. Okay. I'm going to cup the calcaneus, and then I'm going to push into dorsiflexion. So hold on, let me move you. Okay, good. And then for the soleus, we would put a pillow under her knee. We would put it at an end range because it's a one joint, and then we do the same thing, and then just kind of push into dorsiflexion.
Okay, so next we're going to do a talocrural traction. So first what I'm going to do is I want to palpate the joint line and the talus to make sure that I am between inversion and eversion. When I do my traction, I can use my ring fingers to do that. Once I know that I'm right there in midline, so she's in neutral, I can use, I can wrap around and kind of interlace my fingers. Watch my thumbs, I don't want them tucked. I'm going to put her in 10 degrees of plantar flexion. And then you just want to pull down, watch your thumbs, and make sure you're along the joint line or you're perpendicular joint line. It's traction. Next, we're going to do a anterior glide, right? Anterior glide, the talus curl. So what I'm going to have her do is, or what I'm going to do is I'm going to palpate the talus to make sure that, again, it's in neutral. I'm going to use a towel to make sure that her foot is at 10 degrees of plantar flexion and is maintained in that loose packed position. So what we're going to be doing is we're going to actually be pushing the distal tib fib posterior, creating a relative anterior glide. So I'm just going to stabilize at the talus, and then I'm going to push down into the table on the distal tib fib, creating that relative anterior glide. It'll be a firm capsular end feel, and this will promote plantar flexion. Now we're going to do a posterior glide of the talus curl joint. This is going to have the same loose packed position of 10 degrees of plantar flexion. I can palpate the talus to ensure that I am midline between eversion and inversion, so it's neutral, and then I can maintain that 10 degrees of plantar flexion with my leg. So what I'm going to do is I'm going to stabilize the distal tib fib. I have a towel underneath her distal tib fib, so for comfort, I'm just going to wrap around on top to stabilize here, wrap around the talus, have a good force arm, push down to get that posterior glide, and then back up. And this should help dorsiflexion, restore dorsiflexion. We're going to do the calcaneus talus distal traction. So we have her set up in a prone position. I have a towel underneath her tib fib. We are going to have her cross over her other leg so that I have a straight leg here. So what I'm going to do is I am going to stabilize underneath. I can stabilize to make sure her talus is in a neutral position. I'm going to use my web space, these fingers right here, and grasp her distal calcaneus, but we're not pushing through our web space. We're going to be pushing with our fingers, and we're just going to do a distal traction this way. And you can use your shoulder to really put the force in there. So I'm going to stabilize, just apply the force. Doing okay?
Yep. Breathing.
That is definitely a firm capsular end feel. Now we're going to do an intermetatarsal traction, so you can use a wedge or a towel to try and have it so that the part that will remain stabilized will be on the wedge, and then the part that you're going to be mobilizing will be off the wedge, but for now we're just going to use our hands. So if I'm going to traction the metatarsal 2 and 3, I would palpate the joint line on both sides. I'm going to have my stabilization both under and on top, kind of stabilizing the second metatarsal, and I'm going to palpate the third. Just apply a traction that way. You good?
Yes.
Cool. Next, we're going to do the MTP traction. So I'm going to stabilize just proximal to the joint on top and bottom, and then I'm going to be tractioning, so pulling perpendicular to the joint line. So I'm just going to go right on top of her toe on both sides of the joint line, and I'm just going to traction. You definitely get a capsular end feel. This should help with all toe motion if you're tractioning. Next, we're going to go ahead and do the an anterior glide. So I'm going to stabilize proximal again. I'm just going to go on both sides and pull up. Remember, she's to be in 10 degrees of extension as the loose pack position. So stabilize, just pull up. You can feel it moving at the joint line. Definitely a capsular end feel as well. And then for posterior traction, same position, that 10 degrees of extension, and I'm just going to go ahead and push down.
All right, so this is abductor analysis. We're going to make sure that our patient is supine. We're going to grab right distal to the joint, just like this. Make sure the force arm is good. We're going to ask them, can you do this motion? And most people cannot do the motion for this, but just still ask. Placement of the abduction, he probably won't hold.
So you can test for neutral.
Test for neutral, hold, don't let me move you. And he's already in.
Go.
All right, so next we're going to do flexor hallucis brevis and then longus. So for brevis, we're going to stabilize just distal to the joint. We're going to say this is the motion. Can you do that motion? Good. So you're going to stay flexed for me. I'm going to pull out. Hold, don't let me move you. Good. And then we're gonna do longest. So we're gonna. All right, we're gonna do flexor hallucis brevis and longest. We're gonna do brevis first. We're gonna stabilize just distal to the toe joint or hallucis joint.
MTP joint.
Yep. This is the motion. Can you do that motion? Good. We're gonna keep our patient flexed. We're gonna pull at the distal MTP joint. Hold.
The proximal phalange.
Hold on, let me move you. Good. And now we're gonna do longest. So we're gonna stabilize distal to the proximal joint.
IP joint.
Yep. This is the motion.
And you're cupping it so you're not on the flexor tendon or the tendons.
Stay flexed. All right. Hold. Let me move you.
Forces on that distal phalange.
All right, next one we're going to do is flexor digitorum longus and quadratus plantae. Our patient is supine. We want to make sure that our ankle is off the table. We're going to stabilize on top of the foot. We're going to say, this is the motion. Can you do that motion? Good. They're going to stay flexed. And I'm going to pull you out. So hold, let me move you. Oh, sorry. Good.
I was trying to...
Go.
All right, next is extensor digitorum longus and brevis. We're going to have our patient in supine. Again, make sure their ankle is off the table. Our stabilization hand is going to be on the bottom of the foot, kind of make a fist in there, watch your thumb. We're going to say, this is the motion, extending the toes. Can you do that motion? Good. We're going to keep them extended. We're going to make sure our hand goes over all digits and pull it into flexion. So I'm going to say, hold, let me move you. Good.
Go.
All right, next is extensor hallucis longus and brevis. Our patient is supine, our ankle is off the table. We're going to stabilize just distal to the joint. We're going to say, this is the motion, extending the toe. Good. We're going to have them keeping extended and we're going to pull into flexion. So I'm going to say hold. Don't let me move you. Good. All right, we're going to do proneus tertius next. We're going to make sure our patient is in supine, ankle off the table, stabilization hand under or above the ankle. We're going to put them in a dorsiflexion eversion. So we're going to say this is the motion. Can you do that motion? Good. Let's keep it up there and then we're going to pull down. So hold and let me move you.
Go.
All right, next is tibialis anterior. Patient in supine, ankle off the table, stabilization hand above the ankle. We're going to put them in a dorsiflexion inversion. And then this is the motion. Can you do that motion? Good. So we'll keep them up there and we're going to pull down. So hold, let me move you.
Go.
All right, next is tibialis posterior. Our patient is supine, our ankle is off the table. Stabilization is right above the ankle. We're going to plantar flex and invert. So this is the motion. Can you do that motion? Good. Okay, keep them there. And we're going to pull up. So hold, let me move you. All right, next is soleus. We want our patient to be in prone. We would put a pillow under their belly, and because their knees bent to 90 or even more than 90, we want to make sure that we have a towel under the knee for support. We're going to have our stabilization hand below our leg, and our mobilization hand is going to be right under the calcaneus. We're going to say, this is the motion. Can you do that motion? Okay, we're going to keep them up there, stabilize here, and we're going to push straight up on the calcaneus. So
Protect your web space.
Protect the rib space, watch your thumb. Hold, let me move you. Good, 5 out of 5. All right, next is gastroc and plantaris. Our patient is in supine. Leave a towel under their knee for slight flexion. Ankle off the table. Stabilization hand is going to be right above the ankle. We're going to say, this is the motion. Can you do that motion? Good. We're going to keep the foot in neutral. Cup the hand. And we're going to say, hold. Don't let me move you. Good. 5.
Go.
All right, next is proneus longus and brevis. Our patient is going to be in supine. Our ankle is going to be off the table. We're going to stabilize either above or below the ankle for this one, whenever one you feel more support based on your patient. We're going to put them in a plantar flexion and eversion. So this is the motion. Can you do that motion? Good. So stabilize down there. And we're going to pull into inversion and dorsiflexion. So hold. Don't let me move you. Good. All right, next is going to be the one joint ankle plantar flexors. Our patient can be in supine, or you could do this seated. So right now he's in supine. You'll make sure the knee is bent to at least 90, more than 90. Our hand is going to be cupping the ankle and then using our arm for support. Then we're going to have a stabilization arm above the ankle, and we're just going to flex him in and say, where do you feel the stretch?
Ankle.
Good.
Go ahead.
All right, next is a 2-joint ankle plantar flexors. Our patient is in supine. Our leg is straight, our opposite leg is going to be bent. We want a little bit of extension. We're going to cup the calcaneus, arm under the foot, stabilization above the ankle, and then we're just going to stretch. We're going to ask our patient, where do you feel the stretch?
Ankle.
In the ankle.